Hello, dear friends and medicine passionates. Welcome to a new episode of the MedVoice Podcast in a slightly different format. We kept the quality, but changed the language because today we are honored to have Dr. Ross Fisher in our studio as a guest. Dr. Ross Fisher is a pediatric surgeon at Sheffield Children's Hospital in England, where he is leading the pediatric surgical oncology and traumatology for more than a decade. He trained in general surgery and then specialized in pediatric surgery while maintaining a high interest for other fields such as communication and presentation delivery. We will find out more together today. We are very happy to have you here.
It's a pleasure. It is a privilege. I can even speak English as a second language.
First of all, we would like to know what determined you to pick surgery as a career, and more specifically, why pediatric surgery?
So I think in med school we experience the possibility of anything and everything. I went into medicine with that. I want to help people feeling. And I like doing things with my hands. I had sort of practical approach. I thought I might like to do anesthesia, but I honestly didn't think I was clever enough. And I struggled with physiology. And so it was more of a positive choice than that. But I decided that I wanted to do surgery about fourth year in medical school. So I did a 6-year course. So fourth year in medical school, our second clinical year. Why pediatric surgery? I think many surgeons enjoy doing stuff, and so when we do what are called the rotations, we do all sorts of things. So I did neurosurgery, general surgery, colorectal, vascular, orthopedic, cardiothoracics, and I really enjoyed doing all of them, just the practical aspect. But when I did pediatric surgery as part of my rotation, it just clicked that I loved the work, I loved the patients, and I loved the outcomes, because children, the majority of their conditions are congenital. And what I discovered is that if you fix that, or if it's fixed for them, then they go on and live a normal life for them. And that is a real privilege. Whereas adults, we're slowly decaying, and adult surgery is about slowing the decay, not curing many things. So it's a positive choice, the patients and the pathology and the outcomes.
Was there a specific moment that led to this decision?
I keep telling people there was one. I'm sure there were positive decisions, but when I was a very junior general surgical registrar, my chief had some pediatric patients. And there was one episode where I was in clinic seeing a small boy. I think he was about 3 or 4, and he had an inguinal hernia. So I had examined him, and I was sat at the desk a little bit with my legs open to speak to his parents, my leg under the desk to write in the notes. And this kid just came in and sat on my lap. And he said to me, what are you doing? And I said, well, I'm writing notes about you. And he said, why? And I said, well, we talked about this, that you have this poorly and we're going to fix it. And he said to me, who's going to fix it? And I was very junior. I said, well, my boss will fix it. And he was quite adamant. He said, no, I want you to fix it. And that I clearly remember a very long time ago as a point where I thought, yeah, I can do this.
It's clear that your empathy and dedication to this field has started ever since. So after you specialized in pediatric surgery, you've been 1 year in New Zealand. How was that experience for you?
Fantastic. I think I love travel. It's wonderful being here in Romania, meeting old friends again and making new friends. And medicine is a wonderful way to travel because, you can take your Romanian experience and take it around the world. And I was lucky enough to have the opportunity to go to New Zealand, and I worked in the main hospital in Auckland, which is called Starship, for a year. And that was a fantastic experience because they have referrals from all around their country there. So there was different opportunities than I had had in Bristol, where I'd been a senior trainee in London. And in London, the people are friendly, the weather's good, the wine is lovely, and I got better at doing triathlon as well.
in general, in Europe, we tend to go to the Western world. For example, in Romania, we hear about the Western countries. Maybe in England, you hear about UK or Canada. So how did you find this opportunity, or how did it come to you to go to the other side of the world?
It's what you should foster, is just meeting people. So I met Phil Moreau, who was a surgeon from Auckland, at a conference in Birmingham, which was just 20 miles down the road from where I was working. And we were just chatting, and he said, what was I doing next year? And I said, I have no idea. I need to be looking for a job. And he said, why don't you come to New Zealand? So I don't think it's always as easy as that, but the medical world is small, and if you make friends like Dr. Hani, me, Dr. Ghana, who's come from Helsinki, then these are possibilities just to reach out to them and say, can you help? If we can help, we can. If we can't, most of us will just say we can't help. But that's the joy of the medical community, I think. It is a big, strange family where we're not directly related, but we're cousins and friends of cousins, and we look after each other.
Yes, I really enjoy these experiences of medical congresses or medical exchanges, because you don't know when you meet a person and how that person can change the course of your life. Or
I would stop you. They don't change the course of your life. You change the course of your own life.
yes, but with a little bit maybe of an intervention.
Maybe.
Or as you said, even though if you do not know someone, if you cannot help us directly, maybe you know someone, and there's like a chain that goes on. So as you mentioned about your first year in this career, we would be curious, what is it like to learn to perform a surgery on a child when you are still learning about it and not being the best one who can do it? How do you tackle the challenges and the difficulties with this wish to learn?
I think it's a challenging question, because I don't think I'm ever the best surgeon. And so we have to get beyond that there always may be someone else who could be better, but I'm there at that time. And so it's not about looking for the absolute best. And importantly, particularly for those of us who struggle with imposter phenomenon, we need to be clear that it's not about being excellent, but about being good enough. And I was looking this up. I've spoken about this in different places. Voltaire, the enemy of good is perfect. This desire to be perfect, I think, can be destructive in medicine. It's certainly destructive in surgery, but destructive in medicine in general, that our desire for perfection and how that changes the way that we work actually is counterintuitively bad and causes problems. So, to go back to your question, I think you need to be good enough to operate. When, as a surgeon, you operate under someone's guidance, you are effectively their hands doing the work. And it's intriguing just how stressful it is as a chief letting someone do the operation, watching for the slightest move that wouldn't be right. But also in surgery, it tends to be a relationship that you understand the chief understands you, and that there's a trust there. It's not that they're going to go rogue and do something horrendous. So it's within the boundaries of a known skill and a known ability that is an acceptable outcome. Is it the best? No, but I don't think you need the best in every situation. We're not dealing with microns worth of accuracy. When we are, then we need to take that on ourselves. So that was the operation I did on Saturday. Is that I would not let the registrar do that operation because it's too challenging for them. But if the child had been bigger and older in days and kilograms and days, then I would have, but not a 1.2 kilogram baby.
Having done both general surgery and pediatric surgery, what do you think are the principal or the main differences between these two?
Pathology. So, adult surgery is about acquired disease. malignant, degenerative, inflammatory, traumatic, whatever. And pediatric surgery is about congenital disease. So it's a disease of genesis. There's something goes wrong in the embryo pathogenesis. We usually understand it, although every time we open up, there's always a worry that something weird will happen. But it's a different pathological process. The tissues are different and they respond better. So they are more forgiving of our skill level. And the outcomes are better too. Children heal, whereas adults have got lots of other things happening. The comorbidities can be a challenge for recovery that children don't have.
I imagine that in this specialty there are a lot of moments of joy, but also a lot of moments of heartache during the surgeries or even after. And you mentioned in one of your TED Talks that 80% of the children who have cancer actually cure.
Yeah.
So how do you cope with the emotional challenges in the pediatric surgery, especially considering that while death may be less common, it can bring more pain with it?
I don't know. I think, and I mean that because I don't fully understand how I've got to where I am. I have emotion and I get upset and I have good days and I have bad days. It's not a skill that's taught like suturing or critical appraisal. It's something that comes with time and with experience. And for me, I think honesty is the main thing. And respecting the family, that there is a time to be separate from the emotion, but there's also a time to be involved in the emotion. And there's an interesting debate. There's a very old physician called William Osler who wrote a thesis on the concept that physicians should be entirely detached from their patients. And I can see by your expression that you don't agree. And I don't either. But we do have to detach ourselves to a point and at a point to do what we do because it's weird. And I think maybe that's an important thing for anyone to hear. Medicine is weird. You talk to people you've never met about things that they have never spoken to anyone about. You get little old ladies to take their clothes off in front of you and touch them in places that possibly they haven't been touched in decades. You do weird things to people and then I cut them. That's not normal. And we learn in medicine to cope with that and figure it out and to learn to examine patients with appropriate decorum and respect. But still remember that that's a person, it's not just a piece of meat. And so that's odd. And you mentioned it before, during surgery, we do not think about the person. If you do, you're in trouble. Because you can't. You have to not treat them like a piece of meat, because that's what some people think. But it has to be just a technical experience. It's about disconnecting the fistula and reconnecting the atresia. That's what we're doing. If I'm thinking about the 1.2 kilogram child who's the twin of the mother upstairs who was in tears when I spoke to her, then I'm not going to perform as well as I should. But when I'm finished, I need to remember that that's what's going on and then deal with that. How do we deal with death? Death and suffering is hard. I think in medicine we forget that that's just the normal practice. Everyone is going to die. We need to respect it. We need to help people in a way that is valuable for them. And one thing I've learned from a colleague of mine who's a social worker is that we actually don't need to do anything. And what she taught me is that the thing to do in those bad situations is to sit in the rubble. So just sit there with them. It's horrible. And often, particularly as physicians, we feel we need to say something to make it better. To say things like, oh, I'm sure he didn't suffer, or you were lucky it wasn't this, or I'm glad it was short. Just sit there. Yep, just be with people. And actually, I think that's really valuable. And let your emotion be reasonable. You know, if the family are crying, it's okay to cry with them. If they're not, and I'm sobbing, then the natural human thing will be to comfort them.
Mm-hmm.
But I think people really value our humanity as physicians, not the robot. And we have to turn it on and off. There are times when when you're running a cardiac arrest, when you need to be specific and detailed and not think about the person, but get through it. But then when you go and speak to the relative, you've got to be a person. You've got to understand that this is probably the worst day of their whole life and that you are in charge of it. And that's a challenge that comes with experience. And, to the medical students watching this, that doesn't mean you get thrown in there on your first day, but you should watch people and see how they do it and see how you think you might do it and learn and just be a decent human being.
Yeah. It's true that it's important to set boundaries, but it's not always that easy. I mean, even myself, sometimes I go to the hospital and then when I'm leaving, I feel like I'm leaving two different words. So do you have any advice for students who find it difficult to detach from the suffering they see daily in the hospitals?
Yeah, it's not yours. That's it. It's really simple. It's not your suffering, so don't suffer. You can empathize with those people and look after them, but it's not yours to suffer with them. That's theirs, and how they do it is up to them. It's almost paternalistic, this idea that I will carry my patient's suffering with me. Don't do that. They didn't ask you to. We can comfort them, we can cry with them, we can hold their hands, but you need to leave it behind, because you then need to step over that body and go to the next one. And if you carry that with you, that will make you worse. It will not make you better. And therefore, your next patient will have a poorer outcome because of that. So I think it's one of the difficulties in medicine is that we are poor at describing what that is. We don't have the words to say what that is. But it's not that we're unemotional. It's not that we don't care. It's that we have to care in one way and then move on and do the next thing. It's like sticking a needle in a small child is a bad thing to do to them. But if you treat them with the fear and horror that they have that you're doing that, then you won't be able to do it. So you have to depersonalize that so that you can do it and then comfort them afterwards. Now that's weird, I know, smacking a child and telling them you love them. But we have to do that because what we do is weird. So yeah, our behavior is weird. And accepting that it's weird, I think, is the first step in that. That what we do is not normal. And so finding ways to share with people. That's why a lot of us have what in English we call black humor. Bad things happen and we laugh about them. And if you're on a bus doing that with your friend and the lady next door turns to you, then that's not appropriate. But there are spaces where we just need to decompress and laugh about the craziness and cry about the craziness. And then put your white coat back on again and go back out.
I think it also comes with experience.
It does. Of course it comes with experience. And part of it is we sometimes forget. We had a baby on our neonatal unit. We're doing the ward round. There's about 20 people on the ward round, including this first-year medical student. And one of the other babies had a cardiac arrest on the ward round, which is great. There's 10 people there who are able to resuscitate this kid. So we set about resuscitating this kid, and there's cardiac compressions going on. He gets ventilated, gets an intraosseous needle. And then somebody turned around, and this medical student was just stood in the corner, utterly terrified. That was the point where we went, oh, right, can somebody please help the medical student? Because why should you understand these things? And it's not normal. It really isn't normal what we do. And that's it, I think, just accepting that it's a bit weird. But it's a privilege to be with people, and it's something that needs to be done. And if you can do it, then do it better.
So in a shift of perspective, parents on the other side are the other ones in the partnership in order to treat and help a child properly. How do you manage to get their trust in the context of pediatric surgery, and how do you approach discussing with them the child's pathology or problem?
I don't think you gain their trust. I think we have it at first. If you don't have it, then you're never going to get it. It's implicit. Hello, my name's Ross Fisher. I'm the consultant surgeon looking after your child. And, you know, as a foundation doctor or intern or whatever you call them, there is an implicit trust in us. If your patient doesn't trust you when they come in, for whatever reason, it's very, very hard to get that back. I know that's an odd way to say that, but if we remember COVID, where people came in not believing in doctors, not believing in COVID, and not believing in respiratory failure, that's a terrible place to be. Parents, I try and speak simply to them without patronizing them, and as I'm doing with you, gauging your facial expression in everything that I say. There is a tendency for some parents to not want to know, and you have to respect some of that. But there's also a need for them to have it explained to them, however upset they are. So to work our way through that. It needs to be a conversation, so it's questions. Do you understand this? Is not a very good question, because the answer to that is yes, of course, because, you know, I respect you. You've clearly explained it very well. Whereas what I've learned to say now is you must have questions. What are they? Mm-hmm. And that allows people a different way of approaching that. I use simple drawings of the conditions that I'm dealing with, and not animate them, but I will draw. So the operation I did that I was speaking about is tracheoesophageal fistula with esophageal atresia. It's the biggest operation I do because it's this long when you write it down. It's usually in a very small person. So I explain that the food pipe goes, when you swallow something, it goes into your stomach. And when these babies are born, their food pipe doesn't. It stops halfway. And then the other end of it, halfway, has made a mistake and joined on to something else. So what I need to do is find what it's joined on to, disconnect it, and join it up. And then I draw them the diagram to show them that. So I try to remember that I know an awful lot of things that most people don't know, and that if I come across as arrogant, then that will immediately make things difficult for them. So try and find what they understand and take them from there. And that's also valuable because often people get confused. They get confused themselves, and particularly for our neonatal surgical patients, they've come from somewhere else where they've met another doctor who often is either inexperienced or is very inexperienced in surgery. So they don't really understand what's going on. And I need to know what they've been told. And that, I think, is where the conversation is. So what do you understand what the problem is? Okay, this is what I understand the problem is, and this is what I'm going to do. And then I say to them, has anyone said anything to you that makes you still afraid that I haven't spoken about? Oh yes, they said that 20% of these babies die. Okay, I didn't say that to you because that's not my experience. I don't know why that person said that, and try and bring it into that. Speak slowly and ask questions. People really, why should anyone understand congestive cardiac failure or diabetes? You know, I don't. So I'm hoping that if I get those when I get older, someone explains them to me and doesn't assume that just because I'm a surgeon, I do understand them. So it's a challenge, and it's a rewarding challenge. The coolest thing in the world is not doing the operation, but going back and telling the parents that you've just done it. That rocks. It's absolutely the best thing in the world, because for that moment that you're responsible for that, and when it works and you get it right, that's just amazing. That's why we do medicine, whether it's surgery or dermatology or family medicine. when you get the thing.
Speaking about challenges, I guess that every pediatric surgeon has cases that leave a lasting impression on them. Do you have such a case that sticks with you? And if you can tell us about one that made it particularly memorable.
So every physician carries with them cases, and not all of them are good. How we experience those, I think, is complex, and how they shape us is more complex. So that there are days when I remember nearly giving somebody the wrong drug, and it just about broke me. I didn't give them the wrong drug. I didn't even have it in a syringe. I just wrote the wrong drug down, and I remember that clearly. I've operated on babies who've died, and I remember that clearly. So those are the negative ones. Positive ones, so tracheoesophageal fistula that I spoke about. 7 years ago, I operated on a baby with exactly that. And it was a challenge because it was technically very difficult to do. But his parents sent me a card afterwards and found me on Facebook. And the card is inside my locker in theatre. And before I do the big operation, I look at that card.
I remember last year you told us about a case of Hirschsprung disease. Maybe
you want me to talk about that, do you? Okay.
If you want to.
I don't mind. So, for your audience, Hirschsprung disease is a condition where the babies are born with a segment of bowel that doesn't work properly. The nerves to the bowel migrate effectively, like birds in the... Where do we go south? Go south in the summer. That's right. In the winter they go... No, it's the other way around. Anyway, the birds migrate. So the ganglion cells migrate, the neural crest cells, in Hirschsprung disease. And if they fail to get to the end, then the baby's bowel doesn't work properly. It's contracted because it's missing the ganglion cell. And I had a baby who had that condition. And at 2 months of age, I operated on him and did his reconstruction. The surgery went fine. And a month later, he developed something called gram-negative sepsis, an infection related to that abnormal bowel, and he died. And that was upsetting for us all, more upsetting for his parents. And I had to go to what's called the coroner's court, which is a court in the UK where a legal person makes sure that everything that was done was done in the correct way. And so that was fine. We got through that. Upsetting, his family were destroyed. They were very, very sad. And that was the end of that. A year later, I had a telephone call from Birmingham one night when I was on call telling me that they had a child with Hirschsprung disease that they couldn't manage because they didn't have a bed. So could they be transferred to us in Leicester? And I said, that's fine, that's what we usually do. And the doctor on the phone said, there's one problem. This family had a baby 2 years ago who died under your care. So I said, well, that's understandable, but I'll refer him to one of my colleagues. And the doctor said, no, you don't understand. They know that you would be in charge of this baby and they want you to look after her. So, I'm still emotional now. She's 15. She's fine. She's fixed. But that is the coolest thing in the world.
Yes, it's very moving. I remember last year also thinking about it, and it's also inspiring, but also moving, and shows the complexities of this medical specialty where you not only deal with the child but also the whole family, and I think there's a lot of gratitude after. Absolutely.
So there's a common problem. It affects 1 in 5,000 babies called an anorectal malformation, where their bottom doesn't work because it's not there. It's complex embryopathogenesis that we'll not get into. In 1984, a Mexican surgeon developed some surgery for reconstruction of this that revolutionized the world. He's called Alberto Pena. He's still alive, just. He's really old. And he runs workshops where he teaches us how to do his surgery. And what's amazing about his surgery is it is very straightforward, whereas previously there was complex operations that were with a poor outcome. And he is invited around the world because he is such an expert and such an inspiration. And he says what's strange to him is that people offer him money. And he says, I don't want your money. You've given me something more precious. And he said, you give me your child to operate on. I give it back. And that, I think, is that risk, that benefit, that payoff. It's a thing, but it isn't that a pediatric patient is more valuable than a 25-year-old woman or a 90-year-old man.
Definitely.
Every life is valuable, and they're no more valuable if they're newborn or old or poor or a different religion. Everybody is valuable, and I think sometimes we get carried away with the awesome operations on the amazing people, and remember that a GP helping somebody who's worried about their headache to understand that it's not a brain tumor is just the most amazing thing to do as well.
Do you think there are some qualities or vital things that a surgeon has to have, or a pediatric surgeon?
I think we develop them. I certainly don't believe that anyone is born to be a surgeon, and if they think they are, they probably shouldn't be. And I certainly coach lots of colleagues that look down the camera, if you want to be a surgeon, you can be a surgeon. You don't have to be male, you don't have to be big, you don't have to be arrogant and aggressive, and some surgeons are, but that's not what makes good surgeons. I think good surgeons are made by their trainers and by reflection and by coaching, and it's not that there are gifts. What do we have to be good at? You've got to cope when stuff goes wrong. You know, when I made a hole in the inferior vena cava that was 3 centimeters long and half the circulating blood volume came out in 20 seconds. You've got to cope. If you panic, then bad things, even worse things will happen. I didn't get there. I wasn't born to do that, but I learned to do that. When things don't go right, you have to learn to cope with that, but I think that's the same in general medicine or anesthesia or radiology, and it's just different ways that people do it. I don't think there are special skills that surgeons have. I think there are skills that we develop, and that, as I say, if anyone wants to do it, they should do it. And what we don't need is lots of old white grey dudes doing surgery. We need everybody and everybody in between. We need the true diversity so that we can deal with our patients. It's not being male that makes you a good surgeon. I'm sure your viewers, listeners are aware of the New England Journal of Medicine review of surgical complications, that women or people who identify as women have a lower complication rate as surgeons than men do. Now, I firmly believe this is not down to having ovaries or specific chromosomes, but that currently, and sadly, for women to reach that point at which they are senior surgeons, they have to be better than men to get there currently. And so that what we're seeing is the excellence of those people currently in position rather than one's chromosomes and necessarily a way of thinking. But yeah, I think we should have a diverse surgical group, not just made up of men from public schools who think they should be orthopedic surgeons.
So, given your emphasis on the importance of failure, do you think, or could you share a personal experience where the failure or you encountered the moment of failure in your career and how it empowered you or led you to become a better person?
I don't think failure makes you a better person. I think failure is part of all of us, and how we manage failure is what defines us ultimately. There's various quotes, fall down 7, get up 8. There will be trouble in all of our careers, and how we manage that is what will define us and the outcome for our patients. There's a horror that people have in, I think it starts before med school, this perception we have of doctors as being godlike, that is then continued through med school by senior clinicians, that we need to be perfect in every way, and that feeds into part of the characteristics that make us want to do medicine. And so I'll be talking about this later in the Congress if people want to come, but this concept of the imposter phenomenon, where we are terrified of error. And I think what is essential for all of us in medicine, and that includes people who are medical students or wanting to become medical students, or the general public, is that error is ubiquitive. That means it's all around us, and it's not indicative. So that it doesn't mean because you've had a problem that you are bad. And that can be very difficult because the fear of that feeds into some of our ways of processing and cognition and what's called metacognition. And that, for me, error highlights to me that I am crap and that I should stop this and that I'm not worthwhile and that somebody else would not have made that error. And I recognize that that's wrong. Now, it took me a while to get to this place, and some expensive therapy and some good friends and late nights drinking and all sorts of stuff. Can I think of a specific reason, a specific episode? It's probably easier just to say no, but it's about life, is that good assessment of outcome, whether it's positive or negative, allows you to improve. And that if we focus only on things that go wrong, then we'll believe that life is about error. So when I was asked at the coroner's court if I felt that this error was indicative of a pattern of behavior, I said, yes, absolutely. I've done this tens of thousands of times, and this has not happened. And the fact that it did happen in one is not indicative of my error, but indicative of excellence. And that for us as junior doctors putting in needles into veins or prescribing drugs or counseling patients, it will go wrong. We will make mistakes. But the one that is a mistake is not the one that people are looking at. It's the 99 that you did correctly that you should see. Get that one better so that it becomes 10 in 1,000. That's still the same number, but we need to keep progressing and realize that, yes, we will make mistakes because we're human and because medicine is massively complex in not in doing it, but in the complexity of what it entails, and keep trying to get better rather than focusing on error.
In this pursuit of trying to get better, a lot of us medical students, we lose ourselves in studying and keep doing shifts or just studying all the time. And we forget about the fact that there is a life outside of the medicine too.
Yes.
So how did you manage to keep a work-life balance, and if you have some advice for us?
There is no such thing as a work-life balance. That's the first thing. There's work and there's life. And you just have to remember that at some points, the week before your medical exams, you're going to be studying. You're not going to be balanced in what's going on. But when you're not doing that, then take the opportunities to do things that make you happy, that make you remember who you are. When I was in New Zealand, they say to you, so what do you do when they meet you? And you say, oh, I'm a pediatric surgeon. And they went, everybody's got a job, mate. What do you do? And what they mean is, so you've got your job. What do you do when you're not doing that? And if it's sitting on the couch playing video games with your friends, that's okay. If it's riding a bike or fishing or cooking or all of those amazing things you did as a medical student and you've stopped doing them, that's what you should be going back to. Because there is more to life than medicine. And the real sadness is when I'm gone, medicine will still be here. So it's not about me, it's about the future. And so whatever, I don't think there's an answer to that other than to realize that if you spend your whole time studying, that won't make you a better doctor.
Do you have any hobbies or activities that you do outside of the hospital to unwind?
So I'm getting older and not as fit as I used to be. Road cycling is what I do quite a bit of, and I haven't done for 3 months now because of other issues. But just going out, and what I've learned is I'm not competing with anyone. I'm not going to win the Tour de France. I'm not going to keep up with Simon, who's 15 kilos lighter than me and 20 years younger than me. But if I can just keep going and enjoy what I'm doing, then that's a good thing to do. So, yeah, find something that allows you just to do. You don't have to be the best, you just have to enjoy it.
I also know that you have a band. And
I have a band. I'm in a band. I don't have a band. Yes, I sing in a band. You're not going to ask me to sing, are you?
Do you want to sing?
No, I don't have the backing tape with me.
No, I just know that this is like a new thing that you picked up, and I think it's important to let other people know that it doesn't have you don't have to do something from like a long time ago. You just can.
You can pick things up. I used to sing when I was a medical student. I had a guitar and I busked around Europe. I earned some money, but not very much. But I'd always wanted to sing in a band. And then a friend I used to cycle with said that they were looking for a singer. So I would sing in a band. We play in pubs. We headlined a festival.
Wow.
I've learned to say this. So 2 years ago, Bosworth Pop in the Park, we opened the festival at 11:30 in the morning to literally 3 people and a man walking his dog, which was interesting. And last year, we were the headline act, played to 500 people and rocked the place.
Congratulations.
Thank you. I'll tell the boys.
Yeah, tell them from us.
Mm-hmm.
We also know that you are passionate about public speaking.
Mm-hmm.
And communication and presentation delivery. Can you tell us more about this?
I firmly believe that good communication saves more lives than you will as a doctor. Whether that is communicating with our patients or communicating professionally. And when I was doing my research, I had to present my master's thesis. And I did it in the same way everybody else did. And I realized it was really quite awful. And that all of the things that we do in presentations and all of the things that you see your professors do is awful. Now, getting beyond the awful, I actually figured out why it was awful. And there's a lot of science behind what we do being bad. And figuring that out and then helping people to get better makes a massive difference. And it's a real privilege to share those ideas locally, nationally, and internationally and help people communicate better so that their research does change lives, so that their business plan does become effective, so that their keynote speech does inspire people. Because I think copying other people is a really bad way of learning to present. If I copied my anaesthetist, then I wouldn't be a very good anaesthetist. So there are skills, there are simple steps, and simple changes make a massive difference in presentation and education.
And why do you think these skills are important for medical students and for future medical professionals?
They're important because everyone will have to do presentations eventually. And also once you realize why you hate your professor quite as much as you do, it's not necessarily because of who they are, but the way they present. And once you can then separate that, then you see what is wrong with the way they present, then you will be a better learner. Because we are really, really bad at learning. And I learned that when I was learning to be a better presenter.
And how did you pick up this passion, or how did you start?
How did I start? So I was doing a master's in clinical leadership, and the professor said that he wanted us to blog about clinical leadership, because he said anyone can have an opinion, but if you can write 5 paragraphs about that, then you'll start to understand why you have that opinion. So I did that for clinical leadership, and then thought maybe I should start this for presentation skills, because I just hated bullet points. I just noticed that they're everywhere and that they don't work. And so then I started to figure out why I hated them, what was wrong with them, and therefore how to change that. And so that's where that started to come from. Because it's once you have an insight that helps people do things better, then I think you should share that, whether it's about presentation skills, podcasting, or whatever else we do in life. Sharing knowledge is a wonderful thing. It helps the world be a better place.
Do you think that these skills helped you in the departments that you are leading, or made the whole department better in itself?
That is a huge sadness. So that I'm invited internationally to the University of Malmö in Sweden, and they changed their presentations. I've been invited to Chile in Santiago, and they changed their presentation styles. And Sheffield Children's Hospital, pediatric surgery go, nah, it's just Ross. And that's an interesting thing, is that our own ideas often don't mean much to the people around us, because they just see us for the boss, the guy I operate with, the chap I go for a drink with, whereas you see me as something more than my colleagues do, because I've just come to visit you. And it's an odd thing that actually there's some psychological background to it, that we don't see our peers as being as amazing as they are, or their insights as being as deep as they are, because they're just our peers. So that's a bit of a sadness, but there you go.
Maybe in the future.
Maybe.
Do you think that there was anything else better, or maybe not, the better is not the right word, for you to do, except pediatric surgery? If you could
In
choose
life,
again.
If I could choose again, I'd like to have spent more time as a ski coach, because I'm very good at skiing. Nobody believes me, but I used to ski 15 hours a week for 10 years, because there was a dry ski slope in Edinburgh near where I was brought up. So I used to ski all the time, which is very strange for a Scotsman that we can actually ski. But no, I think pediatric surgery is awesome. I would do it again. I would look after myself better as I got through some of the difficult times. I would get better support when I got through some of the difficult times, and believe in myself more than I have done and currently do. But that's about me, not about pediatric surgery.
Interesting. We are getting to the end of our talk, and your insights helped so much. But I think there is another subject that I want to touch, something that you have already mentioned, but is not very much talked to us about in general, and that is the imposter syndrome.
Okay.
Because even though failure is part of our growth and our development as medical students or even as young doctors, we are afraid of it, and often we get overwhelmed by self-doubt, as I'm sure you also experienced. Do you have any practical things that we can do to overcome the imposter syndrome, or even these feelings of self-critique?
No. It's there, and it will always be there. You won't get rid of it, but you can learn to manage it. So imposter, I call it imposter phenomenon, partly because of our tedious medical education. A syndrome is a constellation of issues caused by one individual identifiable cause. And I don't believe that it's a syndrome. I think it's a phenomenon. It affects, apparently, up to 80% of professionals across male and female, and however we identify, that doesn't change. And it happens in those of us who have success. So it's not about failure, it's about challenging our beliefs of our success. So that perhaps you might believe that you have got into medical school because your father knew someone, or that if there had been an interview on a different date, you wouldn't have got in, or that it's only down to luck, or that if you struggle to be as good as possible, then no one will figure out that you're an imposter. The academic literature suggests there are at least 15 identifiable types. I talk about 5 main types, which I can go through if you want.
Please.
Okay. This is my talk for this week. So, sorry. That's the imposter phenomenon. What different types are there? There's the perfectionist. Those of us who believe that if we are not absolutely perfect, then people will find out we're not as good as we should be, and so we'll be caught. There is the superhero who believes that if they just work all day and all night, then no one will find out they're an imposter. There is the expert who believes that the more qualifications you have, the less chance people have of finding out that you're an imposter. There is the natural born hero who has not struggled to get to where they are in their experience, but is well aware that the limits of their ability are about to be exposed, and they're just terrified of that. And there's the fifth one that I now can't remember. And the interesting thing is that now what most people who are doing, listening to this, is rejecting either all of those, saying that, well, that's not true for me, or they're all true for me, and therefore I am not an imposter phenomenon. I actually truly am an imposter. Mm-hmm. So the thing is that this is what's called metacognition. It's a way of thinking about thinking, and importantly, it is false metacognition. So your question is, how do we overcome it? The first thing to do is accept it and actually speak it out loud. Speak it out loud and question it. Because it's in questioning it that we will then have a conversation. Now, I struggle with the right side of my brain is where the negative comments come from. So the left side of my brain, which is a bit quiet and soft, has learned to have discussions with that guy and actually go through those questions. And in those questions, actually challenging the next question that you know that the right-hand brain is going to ask you. And having that conversation out loud. I did that once in a car park, and the guy beside me thought I'd finally lost the plot, I think. Having it in theatre is difficult, but it is partly about just expressing it, because once it's in open daylight, you see what a ridiculous statement it actually is. Because then we're being honest about it. And if you express it to your peers who know you, then they can say, no, you were hired because you were excellent, not because you're pretty. You have done this operation because you are good at this, not because you were just lucky. And even if you feel that in your head and you say it out loud, you realize just how ridiculous it sounds saying it to other people as a conversation. It is tedious where people just say, oh, I'm not very good, looking for compliments, but it's okay to say, do you think I'm any good at this? And that's where what feedback is all about. Feedback is not simply listing the negative faults, as we've talked about earlier, but it's about saying, okay, I see you have doubts. Why do you have doubts about this? I have doubts because I think other people are better than me. Okay, what evidence do you have that they are better than you? And then in that honest conversation of feedback with someone who can support you, then you can start to realize that whilst you have worries, they are only worries, they're not facts. And if you can learn to do that for yourself and be your own coach, then that's a better way to be. But it takes a challenge. It's taken me a long time and I'm not there yet. And that's partly why I share it, so that people look at me and think I'm all that, and I look at myself in the mirror and I don't believe I am, but I still function and I'm getting better.
Every time I listen to you, because we met also in Medicalis last year and also in Surgicon this year, I really feel that you're very grounded and you are naming the things by their name, not trying to give like an empirical solution or something like that. So I'm really thankful that you accepted our invitation to come to the podcast, and I'm sure that everything that you said and the true stories about failure, the advice that you gave, and the reality that you put on the table, honestly, will help a lot of people, because I know I have many colleagues who are facing imposter syndrome, who try to cope with failure, or maybe who don't find their place, or they are struggling with something. I think that's a medical student thing generally. Actually, everybody faces struggles in some way.
It affects everyone.
Yeah.
Part of it is realizing that, talking to people. I was at a conference in Denmark about to talk about this subject, and an intensive care pre-hospital emergency physician, guys who jump out of helicopters and save lives, said, I have this every day of my life. And yet you look at them and you wouldn't think or believe that. So once we start to talk to people and are honest about our worries in life, let alone just our imposter phenomenon, I think that does start to make the world a better place. I have not been good at it, and I really want you and your audience to know that. I'm only lately coming to this, and that's why I'm sharing it. I wish I'd done it a lot earlier. It would have been different. I don't know that it would have been better, but it would certainly have saved me a few episodes of significant challenge in my life.
If we were to conclude, what would be, let's say, 3 advice that you would give to medical students?
3 pieces of advice?
Or 5 if you want to give
Heavens,
more.
I don't think I'm qualified to give any. Never, ever, ever listen to gossips and believe that it's true. Error is ubiquitive, not indicative. You are enough right now to be loved and valued. And if you change anything, that will not make you more loved or valued. That's 4.
Thank you.
It's a privilege. It really is. To share, just to talk. Thank you for the chance.
Thank you for accepting our invitation, and for the audience, when Dr. Fisher comes back to Romania, you should attend the Congress and attend to his lectures, because it's really, really inspiring. We are deeply thankful for you being here and sharing everything with us and giving a piece of the valuable knowledge you have. And yes, we are waiting for you back in Cluj and back in Romania. And I hope you will inspire many, many people the way you inspired me.
Thank you.
Until next time, I am your host, Andreea Mazga, and I encourage you to follow us on social media and send us your feedback. Lastly, I would like to thank all of my colleagues behind the cameras and the entire MedVoice Podcast team behind the scenes. In addition, we would like to acknowledge the Medicalis Congress team who made this podcast possible. Thank you for listening, and see you soon.